Bismillahirrahmanirrahim. Assalamu alaikum. Today inshallah we will discuss another topic, that is the anterior abdominal wall skin and superficial fascia. First of all, we will see the boundaries of the anterior abdominal wall. This is the superior boundary, which includes the costal cartilages of 7th to 9th or 10th rib and the xiphoid process of the sternum. And the inferior boundary includes the inguinal ligament and the superior margins of the anterior lateral aspect of the pelvic girdle. These are the layers which are forming the anterior abdominal wall. This is from superficial to deep. We can see the skin. Beneath the skin, there is the superficial fascia. There are two layers of the superficial fascia. The outer one is the fatty layer and the inner one is the membranous layer. Deep to the superficial fascia, there are three muscles which are present, which are external oblique muscles, then internal oblique muscle, and then the transversus abdominis muscle. Inside and outside of these muscles, there are the deep fascia, which are the superficial layer of the deep fascia. Then there is the intermediate layer of the deep fascia, and then there is the deep layer of the deep fascia. These are the investing fascia. Beneath the transversus abdominis muscle, there is one fascia which is named as fascia transversalis. This fascia transversalis is also named as endo-abdominal fascia. Below the endo-abdominal fascia, there is again the fat. This is named as extraperitoneal fat because it is outside the peritoneum. And beneath the extraperitoneal fat, this is the first layer of the peritoneum or outer layer of the peritoneal cavity, that is the parietal peritoneum. So this is skin, then superficial fascia, then muscles, then there is the fascia transversalis, then there is the extraperitoneal fat and the parietal peritoneum. First of all, we will discuss some of the vertebral levels or some of the levels at which the structures are present. Number one is xiphoid process. See here in the diagram, this is the xiphoid process. It lies at the level of 9th thoracic vertebra, that is the T9. Then the pubic symphysis, it lies at the level of coccyx. Coccyx and the pubic symphysis, they are at the same level. Then the costal margin. See here, this is the costal margin. This is the costal cartilage of 7th, then 8th, the 9th and 10th rib, and this is the inferior point of the costal margin. If we draw one imaginary line which is joining the inferior part of the costal margin, this line lies at the level of L3. See here, this is the third lumbar vertebral level because this is the inferior margin of the costal or inferior plane of the costal margin. This is named as subcostal plane. It lies at the level of L3. Then this is the iliac crest, and there is the highest point of the iliac crest. The highest point of the iliac crest lies at the level of L4, that is the fourth lumbar vertebra. Then the anterior superior iliac spine. See here, these are the two anterior superior iliac spines. They lie at the level of promontory. The promontory is the prominent anterior surface or prominent anterior surface of the body of the sacrum. Then there is the intertubercular plane. What is intertubercular plane? Intertubercular plane is the line which is passing through two tubercles of the ilium. This is iliac crest. There are two iliac tubercles which are about 5 centimeters posterior to the anterior superior iliac spine. This line, it will pass through the iliac tubercles. It is named as transtubercular plane or intertubercular plane. It lies at the level of 5th lumbar vertebra. This is the 5th lumbar vertebra. So the subcostal plane lies at the level of L3 and transtubercular plane, which is passing through the iliac tubercles, it is at the level of L5. Then we can see the level of umbilicus. Umbilicus lies at the level of L3 and L4 vertebra, that is between L3 and L4, or at the level of intervertebral disc, which is present between L3 and L4. Then there is one structure or one line which is named as linea semilunaris. This linea or line which is half moon shaped, this is called as linea semilunaris. It is actually the lateral boundary of the rectus abdominis muscle. This linea semilunaris, it is passing from the ninth costal cartilage to the pubic tubercle. See here, this is the extent of the linea semilunaris. This linea semilunaris, it passes from the ninth costal cartilage to the pubic tubercle. Then there is one transpyloric plane. Transpyloric plane means it is the line which is passing through the pylorus of the stomach. It is between the suprasternal notch and the pubic symphysis. This is pubic symphysis, and here there is the suprasternal notch. So this is the point which is midway between the suprasternal notch and the pubic symphysis. This transpyloric plane, it lies at the level of L1. This is the first lumbar vertebra. Then there is one linea alba, which is the median plane or median line. Okay. Then there is one structure which is named as renal angle. I will show you the renal angle. See here, this is the renal angle at which the kidney is present. This is one angle which is formed by the 12th rib, and medially it is formed by the lateral border of the erector spinae muscle. This is the erector spinae muscle. This angle which is formed by the 12th rib and the erector spinae muscle, this is named as renal angle. In this diagram, you can see the linea alba. This is linea alba, and this is the linea semilunaris. Linea alba is the median plane, and the linea semilunaris is showing the lateral margin of the rectus abdominis muscle. Then the last point is the posterior superior iliac spine. This one is the anterior superior, and here there is one posterior superior iliac spine also, which lies at the level of, which is about 4 centimeters lateral to the median plane. This is median plane, and the posterior superior iliac spine will be about 4 centimeters lateral to the median plane. Now we will discuss the layers of the anterior abdominal wall. First of all, there is the skin. See here, this is the skin of the anterior abdominal wall. When we remove the skin, we can see the superficial fascia. This is superficial fascia. Superficial fascia has two layers, the outer fatty layer, which is also named as Camper's fascia, and the deep membranous layer of the superficial fascia, which is also named as Scarpa's fascia. So skin and superficial fascia and the membranous layer of the superficial fascia, fatty layer and membranous layer. When we remove the membranous layer, we can see the deep fascia over the external oblique muscle. Then we can see the external oblique muscle. This one is the external oblique. When we remove the external oblique, we can see the internal oblique muscle. And when we remove the internal oblique muscle, we can see the transversus abdominis muscle. This is the transversus abdominis muscle. Below the transversus abdominis muscle, there is one transversalis fascia. This is the transversalis fascia which is present. And here below it, there is the extraperitoneal fat. And when we remove the extraperitoneal fat, we can see the parietal peritoneum. So these are all layers of the anterior abdominal wall from superficial to deep. Skin, superficial fatty layer, that is the Camper's fascia, superficial membranous layer or deep membranous layer of the superficial fascia, this is the Scarpa's fascia. Then there is the external oblique muscle, internal oblique muscle, transversus abdominis muscle and transversalis fascia, and extraperitoneal fat and parietal peritoneum. In this lecture, we will discuss the skin and the superficial fascia of the anterior abdominal wall. In upcoming lectures, we will discuss the external oblique muscle and internal oblique and transversus abdominis muscle, and then the fascia transversalis, then the extraperitoneal fat and parietal peritoneum. So, skin. In the skin, we have many lines of cleavage. See here, these are the lines of cleavage. They are constant. They are running downwards and forwards, almost horizontally around the trunk. There is one umbilicus. There is one scar which is named as umbilicus, which is representing the site of attachment of the umbilical cord in the fetus. These Langer lines, they are natural lines, they are constant, and they are the lines of cleavage, and they are for the incisions. If incisions are made along with these lines of cleavage, the incision will be healed very properly and without scar. See here, this is umbilicus. This is the site of attachment of the umbilical cord in the fetus. Umbilicus is the meeting point of four folds of the embryonic plate, two lateral, one head fold and one tail fold. And this is also the meeting point of three systems which are meeting at the umbilicus. Number one is the digestive system, number two is the excretory system, and number three is the vascular system. See here, the digestive system meet at the point of umbilicus through the vitalo-intestinal duct. This is the duct which is connecting the midgut to the umbilicus in the fetus. Then another system, that is the excretory system, is also meeting at the umbilicus. This is through the duct or tube which is named as urethus. Urethus is a tube which is connecting the umbilicus with the urinary bladder. And here the two umbilical vessels which are present in the umbilical cord, they are also connecting the vascular system with the umbilicus. There can be remnant of the vitalo-intestinal duct. Vitalo-intestinal duct is the duct which is connecting or meeting the digestive system with the umbilicus. This vitalo-intestinal duct usually or normally it disappears in the fetus, but if it remains or there is the remnant of the vitalo-intestinal duct, it may be present in the form of tumor at the umbilicus. That tumor is named as raspberry red tumor or the cherry red tumor. This vitalo-intestinal duct can be patent and it can result in the fecal fistula because this is connecting the digestive system, so the feces can come out through the umbilicus. This is named as fecal fistula. Or there can be persistence of the proximal part of the vitalo-intestinal duct. See here, this is the proximal, this hole is the vitalo-intestinal duct, but the distal part has been disappeared, but only the proximal part has persisted, and this is named as Meckel's diverticulum. Or if the middle part of the vitalo-intestinal duct remains, this can form one cyst which is named as enterocele. See here, this is the urethus. What is urethus? Urethus is a tube which is connecting the umbilicus to the urinary bladder. If this urethus does not disappear, this will remain or persist. So there will be dribbling of urine from the umbilicus, or it will form a urinary fistula. In the early fetal life, some loops of intestine normally herniate out of the abdomen in the region of umbilicus. This is named as physiological herniation. It occurs at 6th week, but this herniation, it will go inside, or this hernia will go inside or retracted normally at 10th week of the fetus. But what happens sometimes if this condition may persist? So this is named as exomphalos, or it is also named as omphalocele. That is, the normal physiological herniation has occurred, but it has not been retracted back. That hernia persists at 10th week. This is named as exomphalus or omphalocele. Sometimes there is the failure of development of the infra-umbilical part of the anterior abdominal wall. See here, this is the umbilicus, and the anterior abdominal wall below the umbilicus has not been formed very properly, which results in the ectopia vesicae. Ectopia means if the structure is not present in its normal location, and vesicae is a word which is used for the urinary bladder. So ectopia vesicae is a condition in which the urinary bladder is exposed outside the skin or on the surface of the body below the umbilicus. This is named as ectopia vesicae. In the later life, the weakness of the abdominal wall may lead to the formation of hernia at the umbilicus. See here, this is the hernia which is formed at the umbilicus, which is named as umbilical hernia. It can be because of the weakness of the anterior abdominal wall in old age. Umbilical hernias, they are common in neonates because the anterior abdominal wall is relatively weak on the umbilical ring, especially in the low birth weight infants. Umbilical hernia are usually very small, and they result from the increased intra-abdominal pressure in the presence of weakness and incomplete closure of the anterior abdominal wall after the ligation of umbilical cord at birth. Herniation occurs through the umbilical ring. That is, the umbilical hernia can occur in old age as well as in the neonates also. An epigastric hernia. What is epigastric hernia? If the hernia occurs in the epigastric region through the linea alba, which is the median plane. Okay, if it occurs between the xiphoid process and the pubic symphysis, this is named as epigastric hernia. Or there can be spigelian hernia. What is spigelian hernia? If hernia occurs through the linea semilunaris. These types of hernia, they tend to occur in a people older than 40 years and are usually associated with obesity. The hernial sac composed of the peritoneum is covered only with skin and the fatty subcutaneous tissue. Undue stretching may result in the formation of whitish streaks in the abdomen. See here, these are the whitish streaks which are present in the skin of the lower part of the anterior abdominal wall. These are named as linea albicans. This black line is named as linea nigra. If the anterior abdominal wall muscles are not taut or are not tensed or not very active or not very supportive, then what will happen there? The viscera can protrude out. This condition is named as visceroptosis. In this condition, what happens? The anterior abdominal wall is weak because of the weakness of the muscles. This can be protected by the exercise. If we do regular exercise, the chances of visceroptosis are very less. Now, what is the watershed mechanism at the umbilicus? See here, at the umbilicus, there is the watershed line. With reference to the lymphatic and the venous drainage, the level of umbilicus is watershed. The lymphatic drainage and the venous drainage, they will be flowing upward above the plane of umbilicus and downward below the plane of umbilicus. They do not cross the umbilical plane normally. This is named as watershed mechanism at the umbilicus. Now there is another point about the umbilicus. The skin around the umbilicus is supplied by the segment T10. Although the umbilicus lies at the level between L3 and L4, but the root value or the segment of the spinal cord which is supplying the umbilicus is T10. So do not mix this T10 with L3 and L4. The umbilicus is one of the most important site at which the tributaries of the portal vein anastomose with the systemic vein. There are the portocaval anastomosis which are present normally. These anastomoses between the portal vein and the systemic vein, they drain into the azygous vein and the hemiazygous vein and the lumbar veins. So these are some of the important points which you have to remember about the umbilicus. In the portal hypertension, all those normal veins or the portosystemic anastomosis, they open up and form the dilated veins radiating from the umbilicus. These veins are named as caput medusae. However, the blood flow in the dilated vein is normal and does not break the barrier of the watershed line. See here, this is umbilicus and this is the watershed line. The lymphatic drainage and the venous drainage above the umbilicus will go above, and the lymphatic drainage and the venous drainage below the umbilicus will drain below. So in portal hypertension, what happens in the caput medusae? These dilated veins, they do not break the watershed line. All the veins which are dilated above, they will drain the lymphatic flow and the venous drainage above, and the veins which are below, they will drain the venous drainage below the umbilicus. See here, these are some of the sites along with the umbilicus. These are some other sites at which the portosystemic anastomosis are present. They are present at the area of the lower esophagus, at the region of the upper anal canal, in the umbilicus, at the bare area of the liver, at the patent ductus venosus, and there are some veins which are present retroperitoneal also. These are normal anastomosis between the portal vein and the systemic vein. So if there is the portal hypertension in liver cirrhosis or many other causes, if the portal veins are blocked, so the areas which are drained by the portal vein, they will drain through the systemic vein by the portosystemic anastomosis. The anastomosis will be dilated up, and the portosystemic anastomosis, it will function and drain that area which is now not draining through the portal vein. This was about the skin. Now we will discuss the superficial fascia. As I have already told you that there are two layers of the superficial fascia. The outer one is the fatty layer, which is the superficial fatty layer. It is also named as fascia of Kemper, and the deep membranous layer. This one is the deep membranous layer, which is named as Scarpa's fascia. This Scarpa's fascia, it blends with the deep fascia of the thigh, and it extends into the penis also, and scrotum in males, and labia majora in females, and in the perineum also. And this Scarpa's fascia will become the Colles fascia in the perineum. So this is the superficial fatty layer. It is continuous with the superficial fat over the rest of the body, and this Scarpa's fascia, it will become the Colles fascia in the perineum. The superficial fatty layer. See here, this is the superficial fatty layer. In the scrotum, in men, the superficial layer continues over the penis. See here, it will continue over the penis, but it will lose its fat, and fusing with the deeper layer of the superficial fascia, it continues into the scrotum, and it will form one smooth muscle, which is named as dartus muscle. This is the dartus muscle. See here, what will happen when this fat is coming down from the abdomen? In the penis it will disappear, and in the scrotum it will be replaced by one smooth muscle that is named as dartus muscle, and the fascia over that dartus muscle is named as dartus fascia. In women, this superficial layer retains some fat and is a component of a labia majora. But in males, this fat will disappear in penis but replaced by the dartus muscle in the scrotum. Now the deep membranous layer. This deep membranous layer of the superficial fascia, which is named as Scarpa's fascia, is thin and membranous, and it contains little or no fat. Inferiorly, as I have already told you, this layer, the deep membranous layer, it is continued in the thigh with the deep fascia of the thigh that is named as fascia lata. It is below the inguinal ligament. It will fuse with the fascia lata. In the midline, it is firmly attached to the linea alba and the pubic symphysis. And in the perineum, it is continued as the Colles fascia, which is also named as superficial perineal fascia. So from this diagram you can understand that the deep membranous layer, see here, this is the deep membranous layer, it will be continued with the deep membranous layer of the perineum, which will be named as Colles fascia. This is Colles fascia. This is the deep membranous layer which is present in the penis also, and in the abdomen this is the Scarpa's fascia, and then in the perineum it is named as Colles fascia. Okay, and when in the perineum it is also this Colles fascia, it is also named as superficial perineal fascia. Okay, and in the thigh it will be continuous with the fascia lata of the thigh. See here, when it will be in the thigh, it will be fused with the fascia lata of the thigh. In men, the deeper membranous layer of the superficial fascia blend with the superficial layer as they both pass over the penis, forming the superficial fascia of the penis before they continue into the scrotum, where they form the dartus fascia. Also in men, the extensions of the deep membranous layer of the superficial fascia attached to the pubic symphysis pass inferiorly onto the dorsum and the side of the penis to form the fundiform ligament of the penis. That is, this deep membranous layer of the superficial fascia, when it is coming in the penis, it is forming the fundiform ligament. Here, this is the fundiform ligament of the penis. The fundiform ligament will connect the penis to the pubic symphysis. In women, the membranous layer of the superficial fascia continues into the labia majora and the anterior part of the perineum. Membranous layer of the superficial fascia and the extravasation of the urine. The membranous layer of the superficial fascia is very important clinically because beneath it there is a potential closed space that does not open into the thigh, but it is continuous with the superficial perineal pouch via the penis and the scrotum. If there is rupture of the penile urethra in some road traffic accident or any kind of trauma, it may be followed by the extravasation of urine. That is, the urine will come out from the penile urethra into the scrotum, into the perineum and the penis, and then up into the lower part of the anterior abdominal wall, deep to the membranous layer of the fascia. But the urine is excluded from the thigh because the attachment of the deep membranous layer of the superficial fascia to the fascia lata. See here, this is the external oblique muscle. This one, from here they have removed the membranous layer or the Scarpa's fascia. This is the Scarpa's fascia. This is the deep layer of the superficial fascia. Okay, this is Scarpa's fascia. This fascia, it will be continued into the penis and the scrotum as the Colles fascia, but it is fused with the fascia lata of the thigh below the inguinal ligament. This is the line of fusion of the Scarpa's fascia with the fascia lata of the thigh. If there is rupture of the penile urethra, so what will happen? The urine will come out and it will go into the penis and the scrotum and the lower part of the anterior abdominal wall in the superficial perineal pouch, but it will not pass into the thigh because here the deep membranous layer of the superficial fascia, that is the Scarpa's fascia, it is fused with the fascia lata. From here also you can see if there is rupture of the penile urethra, the urine will come out and it will be in the lower part of the anterior abdominal wall below this membranous layer. There is the deep potential space. Here the urine will accumulate. It will also go into the penis and the scrotum and in the superficial perineal pouch, but it will not go into the thigh because of this line of fusion. This line of fusion is called as Holden's line. There is one Holden's line which begins a little lateral to the pubic tubercle and extends laterally for 8 centimeters. See here, this is the pubic tubercle, and this Holden's line, it will go laterally up till the 8 centimeters. This is the line of fusion of the abdominal superficial fascia to the fascia lata of the thigh. See here, this is the Holden's line. It is about 8 centimeters from the pubic tubercle. This is the line of fusion where the membranous layer of the superficial fascia fuses with the fascia lata. So the urine will not come out. Now we have discussed the skin and the superficial fascia. Now we will discuss the nerve supply of the anterior abdominal wall. These are the anterior rami or the ventral rami of lower 6 thoracic nerves and first lumbar nerve. Lower 6 thoracic nerves are T7, T8, T9, T10, T11 and T12, that is thoracic nerve 7 to 12, and the first lumbar nerve. These nerves, they are present in the interval between the internal oblique muscle and the transversus abdominis muscle. These thoracic nerves, these are the lower 5 intercostal nerves, and the T12 is the subcostal nerve. Again, you can remember that this is the lower 5, T7, T8, T9, T10 and T11. These are the lower 5 intercostal nerves, and the subcostal nerve, which is T12, and the first lumbar nerve, which is represented by 2 nerves. This one is the ilioinguinal nerve and this is the iliohypogastric nerve. These are the 2 nerves which have the root value L1. They will supply the skin of the anterior abdominal wall, the muscles and the parietal peritoneum. Again, you can see here, these are the intercostal nerves, lower 5 intercostal nerves, and the T12, that is the subcostal nerve, and then L1. L1 has 2 nerves here. This is the ilioinguinal nerve, ilioinguinal, and this one is the iliohypogastric nerve. These are the nerves which are supplying the skin and the muscles and the parietal peritoneum. Again, you can see here, this is the transversus abdominis muscle and this is the internal oblique muscle, and these are the nerves which are present between the internal oblique and the transversus abdominis muscle. So remember, T7 to T9, they will supply the skin from the xiphoid process to just above the umbilicus. So remember the root value. This is T7 to T9. It will supply above the umbilicus. T10 will supply the skin around the umbilicus. This is very important root value. Then T11 and T12, which is the subcostal nerve, and L1, they will supply the skin below the umbilicus. The ilioinguinal nerve, which is a branch of L1, supplies the anterior surface of the scrotum and the labia majora and send a small cutaneous branch to the thigh. Again, see, this is T7, T8, T9. These are three nerves, intercostal nerves, which are supplying above the umbilicus. T10 is supplying at the level of umbilicus, and T11 and 12, they are supplying in L1 also. They are supplying below the umbilicus. This L1 will also supply the anterior part of the scrotum in males and labia majora in females. Now, what are the arteries which are supplying the anterior abdominal wall? There are anterior cutaneous arteries. See here, these are the anterior cutaneous arteries, which are the branches of the superior epigastric. This is superior epigastric artery. And there is the inferior epigastric artery. See here, this is the inferior epigastric artery. This inferior epigastric is a branch of the femoral artery, which is the branch of the external iliac artery. See here, the external iliac artery will give the femoral artery, and from the femoral artery, these inferior epigastric arteries, they will come out. Okay, this is the inferior epigastric artery. They are coming out from the external iliac, and the superior epigastric, they are the branches of this. There are the internal memory or the internal thoracic arteries. See here, these are the internal thoracic arteries. So they are giving the superior epigastric artery. These are the anterior cutaneous arteries. There are some intercostal arteries also, which are the lateral cutaneous arteries. See here, these are the lateral cutaneous arteries, which are the branches of the intercostal arteries. Now there are some superficial inguinal arteries also, which are the branch of the femoral artery. This is external iliac, this is femoral artery. This femoral artery is giving some superficial inguinal branches. In these superficial inguinal branches, there are three branches which are supplying the anterior abdominal wall. Number one is the superficial epigastric. See here, this is the superficial epigastric. The inferior epigastric was a branch of external iliac. See here, this is the external iliac. It can come out from the external iliac or the femoral artery from the external iliac. But this femoral artery, it is giving three inguinal arteries. Number one is the superficial epigastric artery. This is superficial epigastric. It will run upwards and medially and supply the skin up to the umbilicus. Then there is the superficial external pudendal artery. This is superficial external pudendal artery. It runs medially to supply the skin of the external genitalia and the lower abdominal wall. Then the third one is the superficial circumflex iliac artery. This is superficial circumflex iliac artery. It runs laterally below the inguinal ligament and along the iliac crest to supply the skin of the abdomen and the thigh. So three superficial inguinal arteries. Number one is superficial epigastric, number two is superficial external pudendal, and number three is superficial circumflex iliac. These are three superficial inguinal arteries which are coming out from the femoral artery, and femoral artery is the continuation of the external iliac artery. This external iliac artery was giving one inferior epigastric, and there was one superior epigastric which was coming out from the internal thoracic artery. So this is the blood supply. Now what is the venous drainage? There are many superficial veins which are present around the umbilicus. This is the watershed line. So all the veins which are above the umbilicus, they are draining into the lateral thoracic vein. See here, this is the lateral thoracic vein. All venous drainage, these are the all paraumbilical veins which are draining the area above the umbilicus. They will drain the venous drainage into the lateral thoracic, and through the lateral thoracic they will drain into the axillary vein, and the area which is below the umbilicus, all veins which are paraumbilical, they will drain this venous drainage into the superficial epigastric vein. Through this superficial epigastric vein, it will be drained into the femoral vein. Okay, and the superficial epigastric can drain into the great saphenous vein, and the great saphenous vein will ultimately drain into the femoral vein. Again, I will repeat, this is umbilicus, this is watershed line. Normally, this watershed line is not broken or not crossed. The area or skin which is above the umbilicus will be drained above. The area or skin which is below the umbilicus will be drained below. Above the umbilicus, it is drained by the lateral thoracic vein into the axillary vein, and below the umbilicus, they are drained into the superficial epigastric vein to the great saphenous vein, and from the great saphenous vein, it will drain into the femoral vein. These are all paraumbilical veins. They will form a network through which the umbilicus they will be drained into the portal vein, or many veins are parambilical veins are present which will drain into the portal vein. So they will form a portosystemic anastomosis here. They will form the portosystemic anastomosis. So the veins accompany the arteries. The lateral thoracic vein, as I have already told you, this lateral thoracic vein will drain into the axillary vein. Then the superficial inguinal vein will drain into the great saphenous vein. But sometimes what happens if there is the portal vein blockage or obstruction, so portosystemic anastomosis will work. They will form the dilated veins here, which are named as caput medusae, and the portosystemic anastomosis will drain all area into the systemic vein. See here, this is watershed line, lymphatic one. Above the umbilicus, all lymphatics will be drained into the anterior axillary lymph nodes, and below the umbilicus, they will be drained into the superficial inguinal lymph nodes. These are the caput medusae, which is formed in the portal vein obstruction, and this is the normal diagram of the venous drainage. This is the above the umbilicus. All veins will be drained into the lateral thoracic, then into the axillary vein, and below the umbilicus, they will be drained into the superficial epigastric, then into the great saphenous, and then into the femoral vein. You can see here, this is the normal lymphatic and the venous drainage. In the portal hypertension also, what will happen? The caput medusae will be present, all veins, the portosystemic anastomosis will be dilated, but they will not break the watershed line. In the inferior vena cava obstruction, what will happen if the inferior vena cava is obstructed? So all venous drainage below the umbilicus or in the lower part of the body, they will be drained into the superior vena cava. It will block or it will cross the watershed line. It will break this line, and all the venous drainage from the lower part of the body, it will be drained into the superior vena cava. But in the superior vena cava obstruction, if it is blocked, so all the venous drainage from above the umbilicus or from the upper part of the body, it will be drained into the inferior vena cava. In these both cases, what will happen? The watershed line is broken. In the inferior vena cava, the venous drainage will go into the superior vena cava, which is above the umbilicus, and in the area of the superior vena cava obstruction, all the venous drainage will come below the umbilicus into the inferior vena cava. See here, this is the way, this is superior vena cava, this is superior vena cava, and this one is the inferior vena cava. So what will happen? All veins above the umbilicus, they are going into the lateral thoracic normally, then into the lateral thoracic vein, then axillary vein, okay, and then they will drain into the ultimately into the superior vena cava. But in the venous drainage below the umbilicus, they will drain into the superficial epigastric vein, and then into the great saphenous vein, and then into the femoral vein, and then in the external iliac vein, and then in the inferior vena cava. Now we will discuss two types of blockage. One is superior vena cava blockage and one is the inferior vena cava blockage. So what will happen if the superior vena cava is blocked? See here, all the venous drainage, when it will come here or accumulate through these veins, and it will try to enter into the superior vena cava. But what is happening here? There is one obstruction or blockage. So all the venous drainage or the deoxygenated blood, it will pass or it will go through the right brachiocephalic vein into the subclavian vein and then into the axillary vein. See here, because here the subclavian vein and the axillary veins, they are present. So through the subclavian vein, it will go into the axillary vein and then into the internal mammary vein. This is internal mammary, which is also called as internal thoracic vein. Through this internal thoracic vein, there is one connecting vein which is present here, that is named as thoracoepigastric vein. Through this thoracoepigastric vein, the venous drainage or the deoxygenated blood will go into the superior epigastric, then into the inferior epigastric vein, and then it will come in the external iliac vein. Through the external iliac vein, it come in the common iliac vein and it will come in the inferior vena cava. So this is the superior vena cava blockage. So blood flow or backflow in the descending order. Superior vena cava is blocked, so the blood will go from the brachiocephalic into the subclavian vein, then into the axillary vein, then in the lateral thoracic vein. Then there is one communicating vein that is named as thoracoepigastric vein. Through this thoracoepigastric vein, the venous drainage will come into superficial epigastric, into the great saphenous, then in the femoral vein, then in the external iliac vein, then in the common iliac vein, and then into the inferior vena cava to the heart. So this is the superior vena cava blockage. So in this diagram, if we assume that if the inferior vena cava is blocked, so what will happen? All the deoxygenated blood which has come here will go in the opposite direction or in the ascending flow. It will come in the back flow. So from the inferior vena cava, if it is blocked, the blood will come back into the iliac veins, which are the common iliac. Then it will go into the external iliac vein, then in the femoral vein, then in the great saphenous vein, then it will come in the inferior epigastric vein to the superior epigastric vein, then into the thoracoepigastric vein, then into the internal mammary vein, then into the axillary vein, then in the subclavian vein and the right brachiocephalic vein and the superior vena cava. So in this way, the blood, if it is not going through the inferior vena cava to the heart, it will come back, and through all this venous system, it will come in the superior vena cava. So in these both cases, what will happen? The deoxygenated blood is breaking the watershed line which is formed at the level of umbilicus.